I'd like to thank Professor Ahmed and the organizers for inviting me to give this talk, and it's my distinct pleasure to be with all of you here in this wonderful meeting. So we heard a lot yesterday and today about CAR T cell therapies. So yes, another CAR T talk. But I'm going to take a little bit of detour here in two aspects. The first one is that this is an allogeneic CAR T. It's not an autologous CAR T, similar to the ones that we've been hearing about for the last day and a half. And secondly, the disease of interest is a T cell malignancy. It's not a B cell malignancy. These are my disclosures. Okay, I'm not going to belabor this because it was covered very elegantly by a lot of presenters, but suffice it to say that the approved autologous CAR T therapies have truly revolutionized patient care in B-cell malignancies. There are currently 7 approved drugs, 5 targeting CD19 for the treatment of B-cell leukemia and lymphomas, and the 2 on the right targeting B-cell maturation antigen and for the treatment of multiple myeloma. We saw this covered very well, high response rates, probably curative for a subset of patients have been achieved, often with minimal long-term toxicities. Now, that doesn't say that there were no short-term toxicities, but long-term toxicities were very mild. However, there are some challenges with autologous CAR Ts. As you know, that the cells are sourced from the patient, and therefore they are damaged from chronic exposure to multiple line therapies, including chemotherapy. The long manufacturing, wait times, it's 3 to 4 weeks currently. It's getting better, but we're not quite there yet. And some of these patients really can't wait for 4 weeks. There's still a likelihood of manufacturing failure, which would be an unfortunate outcome for patients that have already committed to this. And the high manufacturing cost, which was referred to yesterday as the financial toxicity. So allogeneic CAR Ts can address these challenges because the T cells are sourced from a healthy donor. So the benefits of allogeneic is that the harvested cells are healthy, they're not compromised. The product is an off-the-shelf, ready for use, literally within 24 hours from demand. There are usually multiple lots available, multiple doses available, so we don't have the situation where there's a manufacturing failure. And it's more affordable and efficient. Basically, the cost of goods are substantially lower than the autologous CAR Ts. The unmet need that we addressed at Wugen, the company that I'm a part of for the last few years, is that even though there are T-cell malignancies are more aggressive and have inferior prognosis than B-cell malignancies, there are still no approved CAR T therapies for these diseases. In fact, for T-cell malignancies, been sort of the orphan child. There have been no approvals in the last 20 years since Nelarabine in 2005. So why is that? Well, as you can imagine, it's really difficult to target a T cell with a CAR T, right? There are some limitations associated with that need to be overcome by genetic engineering, which is exactly what we did at the company. The first limitation is that because the malignant T cell and the normal T cell express the same surface antigens, it's essentially impossible to completely separate a normal T cell from a patient with a T cell malignancy. And therefore, the product would contain malignant cell. The solution for that is to source the cells from an allogeneic source, from healthy donors, so you don't have this issue of contamination with the malignant cell. But the problem that this solution brings is that the allogeneic T cells induce graft versus host disease. The solution for that is to delete the T cell receptor on the CAR T so that mitigate the alloreactivity so that it would not attack the recipient tissues. So that's the first genetic engineering by deleting the TCR by CRISPR-Cas technology. And the last challenge is that CD7, which is the receptor that is highly expressed on T cell malignancies uniformly, especially in the leukemia setting, is also expressed on normal T cells. So if you generate a product, these CAR T cells would recognize each other, kill each other by a process called a fratricide. And to get around this problem, the solution is to delete CD7 to eliminate the cells killing each other during the manufacturing process. So WuCAR7, which is the name of the product, and that's what I will be using for the rest of the talk, is a dual-edited, CD7 targeted allogeneic CAR T for the treatment of T cell malignancies. This is an overview of the manufacturing process. The T cells are sourced from a normal donor. They contain CD7, obviously, and the T cell receptor. We use CRISPR-Cas technology to delete both CD7 to prevent fratricide and the TCR receptor alpha constant to prevent graft versus host disease. We arm the cells with a CD7 targeted CAR. The cells are expanded in the lab to generate billions of cells. Any residual T cells that still express the TCR receptor are removed by magnetic beads. The product is formulated and cryopreserved in bags or vials, ready to go upon requests. And a single lot can generate approximately 50 to 100 doses. And therefore, it is commercially viable and it's ready to go. So let me tell you about the disease that we have been interested in. It's T-acute lymphoblastic leukemia lymphoma, which I will refer to as TALL-LBL. It really presents, everyone that I talk to here, hematologists tell me that there's a huge unmet need, and that's exactly our impression as well. TALL-LBL is a disease where it represents 15 to 25% of pediatric and adult ALL cases, the remaining 75% being B-cell diseases, leukemias. TLBL is the most common non-Hodgkin's lymphoma in children, representing around 25% of NHL. The TLL and LBL are actually considered the same disease. They're just spectrum of the same disease, with TLL having greater involvement of the bone marrow, usually more than 20-25% the bone marrow. That's a TLL. LBL usually has no or less bone marrow involvement. TLL-LBL is an aggressive disease with high rates of relapse and mortality in both children and adult. Children and adult ratio is usually 50-50. These kids have the disease usually at a young age. Despite the initial responses rates, the disease TLL-LBS has very limited treatment options in the relapsed and refractory setting, and I'll get to that in a second. And CD7, which is the antigen of interest here that we are targeting, is suppressed essentially on 100%. So you can think of CD7 on a TLL like the CD19 on a BALL. So you don't need a companion diagnostic to identify the patients. So for the treatment paradigm, like I said, once the patient is diagnosed, chemotherapy is first line of therapy. 70% or higher numbers respond, you get complete remission. The patients get consolidated and maintenance. If they're MRD negative, hopefully they get an allo transplant because truly it's the only way forward for potential cure. And unfortunately, most of these patients would relapse. And the other 30% or so are refractory to treatment. They don't even respond at all. So we have this relapse refractory population, and this is the population that is unfortunately in trouble. The reason is that there's only one approved drug, nelarabine. It's usually given alone or in combination with chemotherapy. Sometimes it's moved to first line. The responses for the nelarabine are poor. The composite complete remission rate is around 20% with a median duration of response of less than 2 months. And the patients would relapse again, And the next line of therapy, they get salvage therapy. You know, physicians try venetoclax, daratumumab, anything in their disposal just to get a response. But unfortunately, none of these are approved, and they have poor outcomes. So the population that we went after is the relapsed refractory TLL-LBL. So we conducted a clinical trial. This is a phase 1, phase 2 clinical trial. Enrolled 26 patients total in this design. It's standard design, dose escalation, cohort expansion. In the dose escalation part, it's the patient would receive a lymphodepletion chemotherapy composed of fludarabine, 30 mg per meter square per day, cyclophosphamide, 500 mg per meter square per day times 3 days, then a single dose of WUCAR7 on day 1, and then they get assessment of toxicity and assessment of response on day 28, months 3, 6, 9, and 12. 4 dose levels were used. 100 million cells was DL1, transitioning 300, 600, 900 million cells. And based on the toxicity profile, the 900 million cell dose was selected as the recommended phase 2 dose. We transitioned and enrolled 13 more patients with this dose, but we enhanced the lymphodepletion from the standard lymphodepletion that was in the dose escalation. So essentially added another dose of fludarabine and double the dose of cyclophosphamide, and I'll show you why on subsequent slides. The patient population that was included in this trial included adults. This is where we started, and the FDA reviewed the data, and they allowed us to drop the age to 12 years old. So we enrolled approximately 5 or 6 patients that are between 14 and 18 years old. This slide shows the demographics, the patient demographics, and the disease characteristics. The median age was 30, 14, the range of 14 to 69 years old, so younger population, primarily males, which is characteristics of this disease, is usually mostly white, 90-something%, which I left off the slide here. The ECOG performance status was 0 or 1, 1 being 62%. The number of prior lines of therapy, the median was 4 with a range of 2 to 7. The baseline bone marrow blast count, the median was 50% with a range of 5 to 95%, some really high tumor burden in some of those patients, actually quite a few of them. Prior transplant was at least 1 transplant, some had more than 1 transplant, were 40% total, 10 patients. Bone marrow disease was around 40% of the patients. Extramedullary disease was 26%, and bone marrow and EMD were in around 25%. So approximately 50 or so % of the patients had EMD involvement, which is known to be a worse prognosis for this disease. As for safety, the cytokine release syndrome was in 88%. Majority was grade 1, grade 2, 69%. 5 patients, 19% had grade 3 or more. 2 of those were grade 4 CRS, but they were managed with supportive care and completely resolved within the first 1 or 2 weeks. Immune effector cell associated HLH-like syndrome. There was 1 case of grade 2 in this population. ICANS, we observed 2 grade 1 ICANS in this trial. Graft versus host disease, there was 1 event of grade 2. We don't see anything greater than grade 3 or more. Prolonged cytopenias, there was 1 case in grade 1, 2, and 1 case in grade 3. 3 patients had grade 5 events. 2 of them were deemed unrelated to the treatment, and 1 was related to the treatment and had extremely proliferative. This patient, unfortunately, is a really an unfortunate case where this young lady was transported from a war zone in Gaza to Europe. She had 95% bone marrow blast and counts and very proliferative disease by the time she made it to Europe. Unfortunately, she expired a few days after she received the therapy. So, which really highlights the need for having an allo product for this, because a lot of these patients can't wait 30 days to get treatment. As for responses, overall, the drug was effective, surpassing the standard of care. Shown here in the waterfall plot is the magnitude of response versus percent reduction from baseline tumor burden. Except for dose level 1 with the white bars, we saw responses in all dose levels, DL2, DL3, and DL4. But the majority of the responses, as you see here, were in the recommended phase 2 dose of 900 million cells with enhanced lymphodepletion. And at this dose, the overall response rate was 91%. And the
2 minutes of time.
2 minutes? Okay, and the CRC, I speak really slow then. Okay, all right, I'm gonna run through this. The CRC was 73%. The duration of response shown here, the longest duration of response was 10.7 months. The overall response, 6.7 months. The RP2D was not reached. 8 patients were bridged to transplant, and they successfully engrafted. This is one of the clinical vignettes. This is a patient with refractory TLBL, received the recommended phase 2 dose, and you see that the difference between day 0 and day 28, he achieved a complete remission. I'll go, maybe I can skip this one here. Similar, this is a young lady who had blast 55%. She had received multiple lines of therapy, including an autologous CD5 CAR T and 2 transplants. She received the recommended phase 2, responded, MRD negative CR, received a 3rd transplant, and she received a remission and still in remission 9.5 months later. PK, the product expanded pretty quickly and nicely, achieved peak levels on day 10 to 14, declined, but it persisted for around 3 months, and there was no difference between the area under the curve between bone marrow patients with bone marrow disease or AMD disease, suggesting that it doesn't matter really whether the drug expanded. We saw no anti-HLA antigens and drug and ADAs for the product. Let's see here, what do I have? Enhanced lymphodepletion showed better PK than standard lymphodepletion. This is why we went for enhanced lymphodepletion. And this is the regimen that we use. I'm gonna skip this one here. Based on this promising data, the agency gave us the green light to start the pivotal trial for this disease. We have sites open, 2 disease populations. The first one is relapse and refractory, and then MRD positive, basically after first line, MRD positive. And the age is adults and pediatrics. The agency allowed us to drop the dose to 1-year-old. Okay, we have all kinds of indications accelerated from the agency. 3 sites are open in the United States, but this is intended to be a global trial in Europe, Korea, and Australia. I'm gonna skip this because I was gonna tell you here that it could be used for teen and Hodgkin's lymphoma because CD7 is expressed on teen and Hodgkin's lymphoma patients as well. We have a vignette of a clinical trial that we have there as well, and we see responses. And the summary, I think I covered it well here. I don't have to summarize it. So how is that for speed?